In this lecture, we will be talking about trauma and stressor-related disorders in the DSM-5. So, as we've learned, other sections of the DSM contain disorders that might have been prompted by a traumatic experience. For example, phobia, panic disorder, depression. Many of these symptoms and disorders could have been prompted by trauma. Even psychosis, which we talked about, there's a lot of factors that would cause someone to experience psychosis, and it's not necessarily a causal relationship between trauma and psychosis. But with other variables, trauma can increase the risk of or trigger psychosis. So, this section of the DSM, trauma and stressor related disorders, attempts to capture reactions to trauma and stress that are not otherwise covered in these other sections of the DSM. And in this section, what all of the disorders have in common in their criteria is that an individual must have experienced exposure to a traumatic or stressful event. And it's important to differentiate between trauma and stress. So trauma is more severe, and stress is a stressful experience that's less severe or maybe not considered trauma. And as we go through the different disorder criteria, we'll have a better understanding of the definitions of both of these. So here on the slide is a list of all of the disorders in this section of the DSM, and I've broken them into three little parts because I find that's the easiest way to think about them. So let's just look at these first two here. We'll go through these two first. And as with other sections of the DSM, these are disorders that are typically diagnosed earlier in life, in the lifespan. So, reactive attachment disorder, otherwise known as RAD, and disinhibited social engagement disorder, DSED. Both of these disorders result from severe neglect or lack of stable attachments in early childhood. We'll talk about them both more in depth, but it's useful to understand them together. So, RAD is characterized by emotional withdrawal and difficulty forming attachments, whereas DSED involves indiscriminate sociability and lack of reticence in approaching strangers. So we'll understand these both better, but just as a way to kind of remember them, I think of it as RAD is characterized by an individual going inward and symptoms that manifest in a more inward way, this internal emotional withdrawal and difficulty forming attachments, whereas DSED is more outward. It's about outward attachments and outward interactions with other people. So let's look at reactive attachment disorder a little more closely. So the criteria for RAD is withdrawn behavior. This is a key defining factor. Consistent pattern of inhibited, emotionally withdrawn behavior. A way this can manifest is that the child rarely or minimally seeks comfort when distressed, or rarely or minimally responds to comfort when distressed. So that's one key thing, withdrawn behavior. The next is emotional disturbance, which means minimal responsiveness and limited positive affect. And then the next criteria is experience of insufficient care, social neglect by caregivers, or repeated changes of primary caregivers. This could be someone who has had repeated changes of primary caregivers that limit the child's opportunity to form stable attachments. For example, frequent changes in foster care, or this is more rare, but rearing in unusual settings that also limit the child's opportunities to form selective attachments, such as an institution where there's a lot of children and not as many caregivers, or just general social neglect, lack of having basic emotional needs met for comfort, stimulation, and affection. So this criteria is what makes this disorder in this section, remember, of trauma and stress-related disorders. It's this experience of trauma or stress. And lastly, there's an age criteria. Reactive attachment disorder Symptoms are evident before age 5. And in order to be diagnosed with this, a child must have, or an individual must have a developmental age of at least 9 months. And the reason for this is given our understanding of attachments and when, at what point in the lifespan an individual can form attachments, at a developmental age of 9 months, an individual is able to form selective attachments. So before that, it wouldn't be accurate to assess someone's attachments. Next, let's look at disinhibited social engagement disorder. So the criteria here is a pattern of behavior in which a child actively approaches and interacts with unfamiliar adults. The child exhibits at least 2 of the following: reduced or absent reticence in approaching and interacting with unfamiliar adults, overly familiar verbal or physical behavior, diminished or absent checking back with adult caregiver after venturing away, even in unfamiliar settings, and a willingness to go off with unfamiliar adult with minimal or no hesitation. So essentially, the criteria here is, I want to mention culture as well. So culturally inappropriate, overly familiar behavior with unfamiliar adults. Next criteria is experience of insufficient care. So exactly the same as the previous disorder, RAD, this individual must have experienced social neglect by caregivers or repeated changes of primary caregivers. And same age criteria, developmental age of at least 9 months. I do want to clarify one thing about this experience of insufficient care. Individuals or children with this disorder can have secure attachments to their caregivers. The attachments to their caregivers does not have to be disordered in order for them to meet criteria for this. They can still meet criteria about how they interact with unfamiliar adults while still having a secure attachment to their caregiver. So that's just something to note. Okay, so we've covered these first 2 disorders, which are related to childhood and early attachments. Next, we're going to move on to the most significant disorder in this section, which is PTSD. So an estimated 6.8% of US adults meet criteria for PTSD, and PTSD can occur at any age beginning in the first year of life. Symptoms typically begin within 3 months after a traumatic experience, but these symptoms can also be delayed. And over the course of a lifetime, symptom recurrence and intensification might occur in response to reminders of the original trauma. So here on the slide, I've got the criteria. So let's start with this first criterion A, which is exposure to actual or threatened death, serious injury, or sexual violence. So that's the first criteria, exposure to a traumatic experience. And there are a few ways that an individual can be exposed to trauma. So there's 4 different ways that the DSM lists, and I invite you to pause this video and see if you can come up with the 4 different ways that someone can be exposed to trauma. So the first way that someone can be exposed to trauma is directly experiencing a traumatic event. Another way is witnessing an event as it occurs to someone else. The third is learning that a traumatic event has occurred to a very close family member or friend. And the last way of someone can be exposed to trauma is experiencing repeated or extreme details of exposure. So example of this would be first responders, maybe police officers or detectives that work with child abuse cases over and over. being repeatedly exposed to extreme details. So that's criterion A, exposure. So let's pause for a moment as we're going through the criteria for PTSD to talk about this criterion of exposure and this definition of what a traumatic experience can be. So I invite you to pause the video and reflect on these questions here. What are your thoughts on the DSM defining trauma as, quote, exposure to actual or threatened death, serious injury, or sexual violence? Does this fit your understanding? Should we consider less intense but still distressing experiences as trauma? Why or why not? How might defining trauma in this more narrow way, the way the DSM defines it, be limiting? How might it actually be valuable? So I invite you to pause now and reflect on that. Now let's move on to the next main criteria for PTSD, which we're going to go through the 4 of them. The first one is presence of one or more intrusion symptoms. So intrusion, another word for that could be re-experiencing. So re-experiencing the traumatic event. So some ways that this could manifest is through recurrent, involuntary, and intrusive distressing memories coming back of the traumatic event, coming back to the individual. Similarly, recurrent or distressing dreams or nightmares, dissociative reactions, which are essentially flashbacks during which the individual feels like the traumatic event is reoccurring. Or another way this can manifest is psychological or physiological reactions to internal or external cues that symbolize or resemble an aspect of the traumatic event. So something that is associated with the traumatic event. Let's say an individual experienced a traumatic event inside a car with red seats. Let's say they get into a car with red seats and they begin maybe having a panic attack. So that would be a physiological reaction to a cue that reminds them of the event. Okay, next criteria, C, persistent avoidance of stimuli associated with the traumatic event. So this could be avoiding thoughts and memories associated with the traumatic event internally, or external reminders of the traumatic event, like people, places, conversations, certain activities, objects, situations. So this can be something really, this can range from something more obvious, like let's say a traumatic experience of a car accident inside a car with red leather seats, right? They might be avoiding cars or avoiding cars of a certain kind. And what someone's avoiding could be something less obvious. For example, something that seems like, innocuous, like a certain type of food. A student of mine once gave the example of an individual maybe avoiding eating certain foods that their abuser really liked. So that's avoidance. Next one is negative alterations in cognitions and mood. So this one, there's a list in the DSM for all of these different ways that this can manifest. And this one's a little bit, there's really a range here because it's about cognition and mood, but some examples are issues with memory. So an inability to remember an important aspect of the traumatic event, typically due to dissociative amnesia. So kind of blank spots in someone's memory, persistent and exaggerated negative beliefs about oneself or the world. So believing that, like a really extreme self-blame, believing that I am bad or that the world is bad, the world is safe, no one can be trusted. Extreme negative beliefs like that. Just a really persistent negative emotional state. So persistent extreme emotions like shame, guilt, fear, anger, even diminished interest in significant activities, feelings of detachment from others, or persistent inability to experience positive emotions. So that's negative alterations with cognitions and mood. And lastly is marked alterations in arousal and reactivity. And I think of this as feeling on edge. So some examples of this are just hypervigilance, an exaggerated startle response to, for example, sounds, irritability, angry outbursts, issues with concentration, issues with sleep. So that's the arousal component. And then the last two criteria for PTSD are that the duration of the symptoms is more than 1 month. And then, of course, we have our criteria that there's the significant distress or impairment in social, occupational, or other areas of functioning. So the way to remember or think of PTSD is these four main components. We have the time, the duration criteria, we have the exposure to the traumatic event, but these are the four main criteria, right, that we went over: intrusion, re-experiencing flashbacks, avoidance, negative cognition and mood, and arousal. So this is really, what it means to have PTSD. And I do want to highlight here that there is a variability in the clinical presentation of PTSD. You do, as you know, you need to meet criteria for all four of these, but an individual could present with issues more issues in one of these areas than others. So, an individual with PTSD could be really based in fear and anxiety almost. An individual could be more anhedonic, like depressive and just not reactive. On the other hand, someone could be very reactive and have a lot of arousal, hypervigilance symptoms. And an individual could, with PTSD, could have more dissociative symptoms. So in actuality, this can look, PTSD can look many different ways. I also want to touch on diagnosing PTSD in children. So the criteria that we just went through is the criteria for adults and as well as children 6 and older. So there's also another disorder really for PTSD in children 6 and younger, and the criteria is a little bit different. So the criteria here is intrusion, avoidance, and or negative cognition and mood, and arousal. So the biggest difference here is that you don't need to have symptoms of both avoidance and negative cognition and mood. And in general, the criteria here is a little bit more simplified. A couple of things I want to note here. So let's talk about intrusion. For recurrent and distressing memories, these spontaneous and intrusive memories in children might not always appear distressing and might be expressed as reenactment through play. Same with dreams. With children, it might not always be possible to ascertain that the frightening content of a dream is exactly related to the traumatic event. And for flashbacks or dissociative reactions, this might occur as well through reenactment through play. The avoidance criteria is almost the same as for adults. Negative cognition and mood criteria is a bit more simplified. It's really about increased frequency of negative emotional states like fear, guilt, sadness, shame, diminished participated in activities, socially withdrawn behavior, and just reduced positive emotions. And the arousal criteria is pretty similar to that of the adult criteria as well. So that's PTSD in children 6 and younger. Next, let's talk about specifiers for PTSD. So one key specifier that can go with PTSD is with dissociative symptoms. And dissociative symptoms are either depersonalization or derealization. And we will talk more about dissociation in it's part of a different section of the DSM, but let's define it here because it is very connected to PTSD. So depersonalization is persistent or recurrent experiences of feeling detached from and as if one were an outside observer of one's mental process or body. So this could be described as feeling as though one were in a dream, feeling a sense of unreality of self or body or of time moving slowly. And then derealization is persistent or recurrent experiences of unreality of surroundings. The world around the individual is experienced as unreal, dreamlike, distant, or distorted. So that's the specifier of with dissociative symptoms. And then another specifier is with delayed expression. So if this PTSD criteria that we went through is not met until 6 months after the traumatic event, then you would note with delayed expression. Just some notes I want to make about differential diagnosis, differentiating PTSD from other disorders that might have overlapping or a similar manifestation of some symptoms. So anxiety and OCD, an individual can have current intrusive thoughts, but if they have anxiety and OCD, these recurrent and intrusive thoughts are not related to the trauma. Plus, there's an absence of other PTSD symptoms that are required, right? Beyond just the intrusion symptom. Major depressive disorder. So while symptoms of MDD overlap with symptoms of negative cognition and mood, remember, and arousal of PTSD, MDD does not include the symptoms that meet PTSD criteria of intrusion and avoidance. So it's those four things, those four components of PTSD are key. And it's actually quite a lot. It takes actually quite a lot to meet all four of those. Then we have ADHD. So in PTSD, disruptions in the individual's attention and concentration can be attributable to the alertness to danger and exaggerated startle response, as this is part of arousal that we talked about, to reminders of the trauma. Whereas in ADHD, these issues with attention and concentration are not attributed to trauma. Then we've got dissociative disorders, which we'll talk about in a separate lecture. So dissociative disorders may or may not have co-occurring PTSD symptoms. And this is when we would utilize the with dissociative symptoms specifier. And also want to touch on psychotic disorders. So PTSD flashbacks are distinguished from hallucinations and other perceptual disturbances by being directly related to the traumatic experience and by occurring in the absence of other psychotic or substance-induced features. But that's something to think about too. When something might look initially like a psychotic episode, but it could be a PTSD flashback. So we talked about PTSD. Now I want to talk about a disorder I think it's useful to think about in connection with PTSD, which is acute stress disorder. So someone with PTSD might actually have met the criteria of acute stress disorder first. So let's talk about it. Criteria for acute stress disorder includes exposure, right, to a traumatic or stressful event. So exposure to actual or threatened death, serious injury, or sexual violation. So this is exposure to a trauma. And the next criteria is presence of 9 or more symptoms from the following categories: intrusion, negative mood, dissociation, avoidance, and arousal. So this is very similar to the PTSD symptoms. It's just a little bit, you don't have to have criteria in one of each of these 4 categories. They're kind of clumped together for acute stress disorder. So there's a lower threshold for meeting the criteria for acute stress disorder. And the biggest difference here is that for acute stress disorder, the duration of symptoms is 3 days to 1 month after trauma exposure, whereas PTSD is 1 month at least. So that's acute stress disorder. It's similar to PTSD, lower threshold, and lesser duration. So like I said, an individual might meet criteria for acute stress disorder, and then the symptoms go on, and they might meet criteria for PTSD later on. Okay, another disorder in this section is, and I'm kind of in this order, it's like PTSD is the most severe, then acute stress disorder, and then adjustment disorder is, in a simplified way, less severe. So adjustment disorder criteria is the development of emotional or behavioral symptoms in response to an identifiable stressor, or stressors, plural, occurring within 3 months of the onset of these stressors. So these symptoms or behaviors are clinically significant, as evidenced by either of the following. One, marked distress that is out of proportion to the severity or intensity of the stressor, and this is something that's kind of left up to clinical judgment. Significant impairment in social, occupational, or other areas of functioning. And the last criteria here is once the stressor or its consequences have terminated, the symptoms do not persist for more than an additional 6 months. So adjustment disorders is intended to be kind of short term. The symptoms do not persist for more than 6 months. And another thing to note here is this word stressors. So adjustment disorder is not about a traumatic experience or experience of trauma. It's stressors have a much wider definition. So a stressor could be something like a breakup of a romantic partnership. It could be ongoing issues in a partnership or in a marriage. It could be a painful illness. It could be just living in a neighborhood that is maybe in poverty or with a lot of danger. It could be a natural disaster. It could be just moving maybe to a different country, different state. It could be the death of a loved one. So a stressor could be so many things. So that's one component of adjustment disorder, right? The stressor. Then other criteria is these emotional or behavioral symptoms in response to the stressor that are out of proportion to the severity of the stressor. What are these symptoms, right? So this gets identified with specifiers. So with depressed mood, low mood, tearfulness, or feelings of hopelessness are predominant. With anxiety, which is nervousness, worry, jitteriness, or separation anxiety. With mixed anxiety and depressed mood, both. With disturbance of conduct, with mixed disturbance of emotions and conduct, or unspecified. So adjustment disorder there's a big range of stressors, and there's a big range, as you can see here, of reactions to the stressor. And then there's some optional specifiers, which there's two here. One is acute. So the specifier can be used to indicate the persistence of symptoms for less than 6 months. And then I find this next one interesting, persistent or chronic. The specifier can be used to indicate persistence of symptoms for 6 months or longer. Adjustment disorder is intended to be kind of a very short-term disorder, but there is this specifier if these symptoms are ongoing. Next disorder I want to talk about is prolonged grief disorder. And this is a new disorder in the DSM. So criteria for this is death of a close person at least 12 months ago, or 6 months for children and adolescents. So this is the exposure to a traumatic or stressful event. And then persistent grief response since the death, with one or both of A, intense yearning or longing for the deceased, and B, preoccupation with thoughts and memories of the deceased. And then the next criteria is at least 3 of the following symptoms most days for at least the last month: identity disruption, feeling that part of oneself has died, marked disbelief about the death, avoidance of reminders of the death, intense emotional pain, difficulty reintegrating into relationships and activities, emotional numbness, feeling life is meaningless, or intense loneliness. And then a couple other criteria here. It causes significant distress or impairment in functioning. And then I think this one's very important. Exceeds expected social, cultural, or religious norms, right? Because grief is so different for every individual. And this has a lot to do with social, cultural, and religious norms of an individual's wider group, of the society and the culture they're in, but also, smaller groups, even just the culture of their family, let's say. And lastly, is not better explained by another mental disorder or substance effects. So that's prolonged grief disorder. Again, it's newly added to the DSM. There's different opinions on this. Some people are concerned that this risks pathologizing normal reactions to grief. I think the intention of this is to have some kind of indication that an individual is experiencing grief in a way that is significant and warranting clinical attention. And this is, creating a disorder as a way of indicating a need for clinical attention. And lastly, the last thing we're going to talk about is, as you know, for every section of the DSM, there's other specified and unspecified. And I want to talk a little bit about other specified trauma and stressor-related disorder. I think this might come up quite a bit because the criteria of PTSD is kind of, I think, it has a relatively kind of high threshold of what you have to meet, right? We talked about the 4 key criteria. You have to meet all 4. You can't just have 3 of the 4. So I think often people maybe meet criteria for PTSD except for one of those 4. So maybe they don't have dissociative reactions like flashbacks, but they meet everything else. So if they don't better meet the criteria of another disorder in the DSM, it might be best for them to be diagnosed with other specified trauma and stressor-related disorder. And one label for this could be subthreshold PTSD or partial PTSD. So that's when there's a persistent response to the trauma with PTSD-like symptoms, but it just falls short of the diagnostic threshold for PTSD. So that is our lecture on trauma and stressor-related disorders.